Hello. My name is Dr. Francois Ricard. I am an osteopath and a PhD. I am the director of the Madrid School of Osteopathy, EOM, and president of Scientifique European Federation of Osteopaths, SEFO. The topic of my presentation is scientific data on skull tissues and mechanisms of action of cranial techniques. Cranial techniques: Sutherland, balanced, functional, articulatory membranous tension, suture thrust, intraosseous lesion modeling, etc. How do they work? At the origin of osteopathy. Osteopathy is anatomy, always more anatomy. Andrew Taylor Still. Osteopathy is physiology, and more physiology. John Martin Littlejohn. Let's apply these two concepts to the skull. What about the anatomy? The scalp. The scalp is made of 5 layers. First layer, skin and hair. Second layer, layer of connective tissue, fatty and fibrous tissue. Third layer, aponeurotic epicranial aponeurosis, and dense fibrous tissue that runs between the frontal and occipital muscles. Fourth layer, loose areolar connective tissue with bundles of collagen and blood vessels in the scalp. Fifth final layer, periosteum of the skull. Nerve supply of the scalp. The scalp and dura mater are innervated by a rich plexus. 3 branches of the trigeminal nerve, 5th, Gasser's ganglion and its branches. 3 upper cervical nerves. Cervical sympathetic trunk. Lower branches of the vagus nerve, 10th, and hypoglossal nerve, 12th. Branches of the facial nerve, 7th, and glossopharyngeal nerve, 9th. Cranial bones. The flat bones of the cranial vault are made up of 3 layers. The outer table of compact bone in contact with muscles, fasciae, and scalp. The diploid or spongy bone layer. The inner table in contact with the cranial meninges. Nerve supply of the bones in the skull. There is a consistent and often dense innervation of the periosteum. Sympathetic nerve fibers associated with vascular elements, in bone and periosteum. Network of meningeal nerve fibers, mandibular nerve, 5th 3, and maxillary, 5th 2, division of the trigeminal ganglion, 5th, and the trigeminal spinal tract. These fibers extend along the intracranial cavities of the emissary veins and in the sutures. The picture on the left side shows the intracranial origin of pain fibers that innervate extracranial tissues, periosteum, muscles. They are variable nerve fiber density. Per every 100 fibers in the periosteum, they are 2 in bone marrow, and 0.1 in cortical bone. Jerome et al., 1987, indicate they are a calcitonin gene-related peptide and immunoreactive nerve fibers of substance P that produce vasodilation in periosteum, compact bone, and bone marrow. They are cholinergic parasympathetic fibers in bone tissue, responsible for bone metabolism. They produce an increase of bone mass and decrease the osteoclastic activity. The picture on the right side shows the parasympathetic innervation in cranial bone, A and B, acetylcholine-positive nerve fibers, AROS, BT, bone trabeculae. According to Artico et al., 2002, autonomous innervation directly participates in hematopoiesis. The effect of circadian rhythms on bone metabolism. During the day, they are peak of bone absorption, where the sympathetic activity is dominant. During the night, they are bone formation, where the parasympathetic activity is dominant. The picture on the right side shows the action of the neurovegetative system on the bone formation of the skull. Blood supply of the skull bones. There are vascular channels that cross the inner cortex of the skull, and facilitate interaction between the brain and the bone marrow in the skull, via the meninges. The cerebral and external carotid arteries, and the diploic veins, provide a rich blood supply via the meninges. Meninges. The dura mater is made up of thick layers of collagen, and arterial, venous, and lymphatic components. The dural lymphatic vessels transport immune cells from the CNS to the periphery. According to De Grey and Mata, 2005, and Sudiwala and Knox, 2019, the intracranial dura mater and pia mater are innervated by neurons, which exhibit properties characteristic of nociceptors, including chemosensitivity and nerve sensitization, a greater ability to respond to mechanical stimuli, and increased intracranial mechanosensitivity. In the picture, we can observe intracranial meningeal nociceptors, which innervate the dura mater and pia mater. They emit collateral branches that cross the cranial vault sutures from the inside to the outside of the head. Intracranial meningeal nociceptors, which innervate the dura mater and pia mater, emit collateral branches, which cross the sutures in the cranial vault, from the inside to the outside of the head. The illustration shows from a branch of the fifth cranial nerve, trigeminal nerve, indicates the nerve supply of the scalp, galea, cervical muscles, cranial bone of the vault, from the innervation of the dura mater and pia mater. Observe the nerve fibers cross the sutures from the inside to the outside of the head. Intracranial meningeal nociceptors, which innervate the dura mater and pia mater, transmit nociceptive signals to the nuclei of the trigeminal spinal tract, originating from the pia mater, cortical surface, dura mater, cranial periosteum, and pericranial muscles. The two dissection photos show the course of the middle meningeal nerve, in the dura mater of the middle fossa of the skull. To understand the action of cranial techniques, Sutherland, articulatory techniques, and thrust techniques for the sutures, etc., we need to understand certain scientific data about sutures. Sutures are joints, made up of connective tissue, that connect the bones in the skull. They are heavily involved in both normal craniofacial growth and development abnormalities. The picture shows different types of cranial sutures: plain, denticulate, serrate, and squamous sutures. Sutures are synarthrosis joints, which connect the bones in the skull via a fibrous sutural ligament. According to Zhang and Yang, 2015, sutures have two interlocking components: the bones and a narrower, flexible layer of collagen fibers. In some sutures, cartilage has been found in the margins of the bones, or in the sutural tissue. The photography on the right shows cartilage that extends, from one parietal to the other, through the sagittal suture. There are 5 intermediate layers, and 2 tie layers, that comprise the basic structure of a suture. The picture on the left side shows a general microscopic construction of a suture. Observe the capsular layer in each edge of the bone, the cambial zone inside, between the bone and the cranial bone, the sural ligament in the middle plus a peripheral union layer. The two views on the right show the aspect of the sagittal suture in microscopy. Nerve supply of the sutures. Many authors identify the presence of adrenergic nerves. Fibers of the trigeminal nerve, fifth cranial nerve, which innervate the extracranial tissues which pass through the sutures. A higher concentration of these extracranial pain fibers is mostly found in the sutures. The histologic pictures on the right show the presence of nerves in the sutural tissue. Several authors show there is a concentration of extracranial pain fibers, collateral branches of meningeal fibers, located in the sutures, which is believed to mediate pain caused by migraines. There is a network of sensory fibers, of the axons of intracranial meningeal nociceptors which reach the extracranial tissue via the sutures. The microscopic view on the left shows bundles of nerve fibers, coming from the dura which invaginate in sutures of the skull. There are bundles of nerves which branch out from the dura mater into the sutures. On the side of the periosteum, there are nerves which branch out into the sutures. Sensory innervation from the scalp, from afferent axons which pass through the dura mater, and the skull through the cranial sutures. The picture on the right shows calcitonin gene-related peptide of the nerve fibers, which cross the arachnoid mater, between the dura mater and the pia mater, in the leptomeninges of the cranial vault. This picture can explain to us that a compression of the suture can irritate these intrasuturales nerve fibers, and cause suture pain. Blood supply of the sutures. Durandou et al., in 2008, demonstrated the presence of a large vascular structure within the cranial sutures, with its network of paravascular orthosympathetic fibers. The pictures on the right show cross-sections of blood vessels, red lines, at the margins of the bone tissue, blue lines, and the suture, green lines. What about physiology? The elasticity of the bones in the skull. Because the bones in the skull are made up of layers, the mechanical properties of the cranial bones can change. The elastic modulus increases, and the diploe causes the thickness of the cranial bones in adults to increase, thereby increasing their resistance to flexion. The picture on the left shows compression, traction, and shear stresses of a cranial bone. The diploe layer absorbs energy, and reinforces bone structures and foramina efficiently. According to Burwa et al., 2013, the deformation rates is near 100% per second. The picture shows tension deformation curves, for cortical and trabecular bone, in compression and tension. The elastic modulus is the slope of the initial portion of the curve. We can see that the cortical bone resists better to compression, and the trabecular bone to tension. According to McElhaney et al., 1970, Peterson and Decal, 2003, the cranial bones appear to be transversely isotropic, and are generally much stronger and stiffer in the transverse direction, or tangential to the direction of the skull, compared to the radial direction, center out. Isotropism. Having properties that are identical in all directions, has invariable properties. Isotropic materials, therefore, have an elastic modulus, a Poisson's ratio, a thermal conductivity, a coefficient of thermal expansion, etc. identical in all directions. The tangential compressive modulus is generally 2 times greater than the radial compression. The figure shows the modulus of elasticity to compression. Below frontal bone, laterally parietal, above occipital. The sagittal, occipitomastoid and coronal sutures are shown in plain lines. Isotropy. A characteristic of certain structures, whose physical properties do not depend on the direction in which they are examined. Isotropic materials have an identical elastic modulus, Poisson coefficient, thermal conductivity, coefficient of thermal expansion etc. in all directions. Orthotropic. Material that has different mechanical properties in different orthogonal directions, that is, at 90 degrees angle. The figure shows several types of anisotropy, typically found in bone tissue. Alford et al., 2015, have described hydrated mineralized extracellular matrix cells giving mechanical qualities to the bone. Organic materials, collagen, proteoglycans, glycoproteins, giving flexibility of bone tissue. Inorganic materials, calcium and phosphate, giving strength of bone tissue. Collagen fibers have thixotropic and piezoelectric properties, which adaptation extends to the mechanical tension placed on the tissue. The bone is made up of viscoelastic tissue which allows deformation during movements and during a trauma. The mechanical stimulation sent a biological signal of mechanotransduction to bone tissue. According to Goldring, 2015, tension in the proteins in the cell membrane, integrins, allows changes in spatial structure modification. Osteocytes play a fundamental role. Mechanical stress, hydrostatic pressure, fluid flow are stimuli for the osteocytes. There are two types of fluids within the bone: blood, venous and arterial, and interstitial fluid. The interstitial fluid dynamics of bone tissue have an important role in bone deformation. Changes in interstitial flow are detected by osteocytes. Mechanical properties of sutures. The sutures can sustain and transmit loads, absorb energy, and provide flexibility to accommodate growth and protection of mechanical stresses. Resistance to flexion in the sutures increases with interdigitation. This figure shows the stress fields in different suture morphologies: A. Straight suture, B. Pure sinusoidal suture, and C. Two-order hierarchical sinusoidal suture. Sutures have transverse isotropy and are viscoelastic. Physiologically, sutures are generally subject to extrinsic impact from a load such as repetitive blows that produce vibrations, hammer technique. The morphology of a suture is affected by its dynamics and its elastic modulus. The arrangement of the sutural fibers will also affect its dynamics. The diagrams show the variations of stress peak ratios in the isotropic models as a function of the suture elastic modulus. According to Savoldi et al. 2017, variations of stress peak ratios in the isotropic models as a function of the suture elastic modulus. Internal to the suture ligament, S. Internal to the bone, B. Combined, C. Deeply interdigitated sutures are seen in areas of high compression, while non-interdigitated sutures are seen in areas of tension. The pictures give an example of suture, S, and respective surrounding bone, B, during testing with considerable elongation of some filaments of the sutural ligament, arrows, according to Savoldi et al., 2017. Collagen fibers are clearly arranged to resist compression at the level of the internal suture, and tension at the level of the interfrontal suture. The interdigitations of the bone serve to increase surface area for collagen fiber attachment, as well as provide areas for obliquely arranged, compression-resisting fibers to attach. Schematic drawings of the expected bony and fibrous morphology of compressed and tensed sutures according to Rafferty, 1999. A compressed suture with deep interdigitating processes and compression-resistant collagen fiber arrangement. B. A tensed suture with shallow interdigitating processes and tension-resistant collagen fiber arrangement. Modulus of dynamic elasticity, and Poisson's coefficients of deformability of the skull, due to a slight pressure, 500 grams, at the level of a beveled harmonic suture, according to Hernew, 1999. Deformation of the suture, 25 microns. Deformation of the bone, 25 micrometers. Deformation of the suture, 25 micrometers, force applied on the external bevel. Deformation of the bone, 6.49 micrometers, force applied to the internal bevel. The diagram on right, taken from a study published by Hernew, shows the deformation of a beveled suture. This was done using the Poisson coefficient of deformation. Sensitization of bone tissue. Howell and Willard, 2005, extended the Van Buskirk nociceptive model to the cranial bone, to explain central and peripheral sensitization. The palpatory sensitivity, allodynia or hyperalgesia, of a dysfunctional tissue is one of the parameters that indicates a somatic dysfunction, associated with central sensitization. Cowan and Cardozo, 2015, indicate that dorsal root neurons can be activated and sensitized by bone tissue. In 1990, Richard Van Buskirk proposed the role of nociceptors in the development of somatic dysfunction. The stimulation of nociceptors is responsible, first for nociceptive reflexes in the direction of the spinal cord that cause an activation of muscle shortening. The maintenance of this shortening is responsible for a reorganization and shortening of the connective tissue. Secondly, of an activation of the orthosympathetic system responsible for vasomotor disorders and tissue edema. Visceral effects with modification of secretions and peristalsis. Immune effects. Fusion age of the sutures in the cranial vault. Osteopathic theories that support cranial bone movement suggest that cranial sutures do not fuse at all during a person's lifetime. The reality is as follows. Sagittal, coronal, and lambdoid sutures fuse at 31 years, 38 years, and 47 years, respectively. The occipital mastoid and parietomastoid sutures do not fuse until 70 to 80 years of age. The sphenoparietal and sphenofrontal sutures fuse around 60 years of age. Complete fusion of the sphenotemporalis is rare. The frontozygomatic suture fuses at 95 years of age. Fusion of the sutures and synchondrosis of the base of the skull. These two pictures show different cartilaginous elements. The picture on the left side shows a 4-year-old child showing only remnants of the anterior intraoccipital synchondrosis. The hypoglossal canals appear posterior to the anterior intraoccipital synchondrosis. The picture on the right side shows the skull base of a 5-year-old. We can see the sphenooccipital synchondrosis, the petrooccipital fissure and the occipitomastoid suture. Age of fusion of the sutures and synchondrosis of the base of the skull. The sphenofrontal suture fuses after 6 months. According to Belden et al. 1997, sphenobasilar synchondrosis fuses at 12 to 13 years of age in girls and 14 to 15 years old in boys and ossifies at 20 years old. The sutures of the skull base fuse at 6 months of age, 50% at 24 months, 84% of the anterior skull base is completely ossified. This table shows the age of fusion of the sutures and synchondrosis of the base of the skull. Mechanisms of intraosseous dysfunction. Molding and intraosseous lesion. When the fetal head descends through the birth canal, movement of the sutures and fontanelles allows them to be displaced or to overlap, to reduce the head circumference. The resulting skull deformity included posterior and superior displacement of the parietal bones and elevation of the occiput. A CT scan of a newborn baby will show that this generally disappears on day 7. Except if does not disappear. The picture on the right shows an intraosseous deformation of the posterior cranial sphere, and asymmetry of the temporal bones. Intraosseous dysfunction is characterized by restricted flexibility, with distortion of the fibrous components of the bone tissue matrix, or non-ossified cartilaginous, or membranous areas. Traumas or strains are responsible for restrictions in the not yet fused cartilaginous joints. Tension and asymmetrical growth, Dopesh law, during bone development, cranial plagiocephaly. Constant afference, caused by stress or loss of mobility in bone tissue, is responsible for autonomous efferent reflexes, who produce alteration of vasomotor activity. The picture on the right side shows an intraosseous deformation of the mandible, asymmetrical condylar processes, and foramen magnum, temporal bulge. The mechanisms of action for cranial techniques. Mechanism for suture thrust and other cranial techniques. Cranial techniques cause a gliding of the scalp, the dense connective tissue, and other tissue layers. They have actions on blood supply, proprioception, continuity with the connective tissue of the sutures. Cranial thrusts rapidly stimulate the superficial teguments, creating a neurological reflex in the area, with an increase of blood supply, and reorganization of myofascial tone. It produces a stretching effect of the intersutural connective tissue, which stimulates the pressure, or traction of nerve receptors in the sutures and the periosteum, innervated by various cranial and cervical nerves. This image is taken from a study carried out by Upledger and shows the intersutural ligaments under an electron microscope. Observe the presence of mechanical captors used to measure pressure, traction, and nerve fibers that transmit pain. Articulatory cranial techniques also act on bone elasticity and thixotropy by warming the bone matrix. The more the body is subjected to shear forces, the more its viscosity is reduced. A study of the dynamic moduli of elasticity skull and suture, deformity coefficients applying light pressure, 500 grams, on the skull, Hernieu, 1999, shows that cranial techniques affect the elasticity and viscoelasticity of the bone, and the sutures. Force used when applying cranial techniques. Sutherland, suture thrust, bone modeling, articulatory techniques, etc., will affect the bone and sutures, the dura mater and other tissues, modifying the local vascularization, and affecting the cranial foramina, and nervous proprioception. These techniques can affect central and peripheral nerve sensitization, the cranial and upper cervical nerves, via craniosutural nerve supply, and the dura mater innervation. Conclusions. 1. Conclusions from the anatomy. The scalp. Through nerve supply by trigeminal nerve, 5th. 3 superior cervical nerves. Cervical sympathetic trunk. Vagus nerve, 10th. Hypoglossal nerve, 12th. Facial nerve, 7th. And glossopharyngeal nerve, 9th. It is possible that the absence of gliding, due to adhesions between the 4 layers, produce irritation/sensitization of these elements. The skull bones and periosteum. Sympathetic nerve fibers, plus meningeal nerve fibers of the trigeminal spinal tract, are responsible for an increase of sensitization of these elements. Through the vascular channels, they are an increase of blood supply in brain and spinal cord. In case of intraosseous lesion, it happens changes to the viscoelasticity which increases bone elasticity. The dura mater. Collagen, arterial, venous, and lymphatic components, contain immune cells, going from the CNS to the periphery, which increase the immunity. Meningeal nociceptors of the trigeminal spinal tract cross the sutures, from inside to outside. For this reason, in the suture, mechanical stimuli and intracranial mechanosensitivity can increase the nervous sensitization. The sutures. Sutural ligament of collagen fibers, with sensory fiber, and meningeal nociceptors of the trigeminal nerve, 5th cranial nerve, for extracranial tissues which pass through the sutures, can be irritated in the sutures. So, the decompression of these elements can decrease pain and nervous sensitization. Adrenergic nerves and large vascular structure can produce an increase of the local blood supply. 2. Conclusions from cranial physiology and biomechanics. Sutures. Cranial sutures permit the craniofacial growth, and the developmental abnormalities. The roles of the sutures are support and transmit loads, absorb energy, give flexibility and protection. His isotropic and viscoelastic characteristics, plus a significant dynamic elastic modulus, and Poisson's coefficients of deformability, allows us an action on the elasticity and change of conformation in case of intraosseous lesion. Very interdigitated sutures in areas of high compression indicate us that it is better to use techniques with traction. But, in not interdigitated sutures in areas of tension, it is better to use techniques with compression. Mechanisms of all cranial techniques. Techniques with gliding of the tissue allows a stretching of the scalp, intersutural conjunctive tissue, as well as dura mater. Techniques with pressure or traction stimulate the nerve receptors and produce neurological response, responsible for a decrease of nociceptive stimulus, reorganizes tensions or local myofascial tone, and increase blood supply. Cranial articulatory techniques act on bone elasticity and thixotropy, through warming up of the bone matrix. When there is an increase of the shear forces, there is a decrease of viscosity. This changes bone and sutural elasticity, decompresses nervous elements, reorganizes tensions or local myofascial tone, increase the blood supply. A small pressure of 500 grams on the skull increase the bone elasticity and the viscoelasticity of the sutures and bones, cranial foramina, cranial sinus, which act in cranial nerves, blood supply and immunity. Techniques that work through the innervation of the skull bones, sutures and dura mater, are responsible for a decrease of central and peripheral nervous sensitization, through the upper cervical spine innervation and cranial nerves. They increase the nerve proprioception. Here is a list of all the 100 references, in 11 slides, that were used for this study. Thank you for listening.